Evening, everyone. Thanks very much for joining our latest Injury Rehab Network webinar with in partnership with Sterosport. Apologies for those of you that have had the introduction before. I'm Andrew, and I lead on our work in sport Sterosport healthcare and host these webinars with Ollie from Basra. Unfortunately, Ollie can't help online. He's busy with his childcare this evening, so I'm just hosting this. But thanks very much to Professor James Hole for kindly being here to share his expertise around respiratory issues in sport. It should be another really good presentation. Just a bit of housekeeping to kick off. Please introduce yourselves in the chat box. We will send certificates to all those who join the webinar live shortly after the session. If you're watching the recording, unfortunately, you won't get the slides then. We'll also send out a link to the recording of the session. James's presentation will be for around 30 to 40 minutes, followed by some question and answers after that. If you could please use the Q&A tab to put your questions into the box there. We'll then pick the most popular questions to put to James at the end of the session. You can upvote any questions that you like, or if there's one that similar to a question that you're asking yourself. So Sterosport is the sports division of Steroplast Healthcare. Essentially, we're a medical supplier based in Manchester, over 30 years experience in working in healthcare and sport. As you can see, it's a whole range of different consumables that we have available, and we're really pleased to work in partnership with different teams, national governing bodies, clinics and facilities. So please do let us know if there's anything we can help with. The Injury Rehab Network has been running since 2019 in partnership with Basra. And I think we're over 60 world-class guest speakers such as James, who kindly sort of share their knowledge and expertise. So we're extremely grateful that we continue to get such a high caliber of practitioners involved. You can find the event details online at the links there. The next event is on the 11th of May with Dr. Adam White from the Professional Football Association, and Adam's going to be talking about brain health and some of the current evidence and insights from that. So that's the introductions from me. Thanks very much again for joining, and thanks very much, James, for kindly giving up your time for the presentation this evening.
Fab. Thank you very much, Andrew. So I am just going to try and share my slides before we start. Can you see that okay?
Yes.
Perfect. So listen, thank you for that nice introduction. And it's lovely to join you on a Monday evening for a webinar. What I'm going to talk about over the next 30 or 40 minutes is how we can try and help athletes overcome problems with their breathing and other respiratory or common respiratory problems such as cough and wheeze. And listen, I mean, this is the area I work in, so I spend a lot of time being referred people and athletic people who are struggling with this. But of course, this presentation comes in lots of different guises. And I recognize that for many of you, you may be seeing an individual, helping them with a completely different problem. And then suddenly they mention to you, well, you know, my breathing's not been so good, or my asthma's playing up for me, or I've got some issue with hay fever this time of year, which makes my sport less enjoyable because I can't breathe properly. And, you know, it has the potential to really spoil enjoyment of sport. It has a potential to impede performance, has the potential to stop people going and joining clubs or keeping up with teammates. And so, as I'll share with you over the next few slides, the impact is far more far-reaching than just trying to work out a diagnosis and get people to the right treatment. Of course, you know, we put our athletes through a lot of different respiratory challenges just by virtue of the environments that we expect people to perform sport in. The lung is the first sort of port of call for the sort of toxins and inhalants that people are exposed to, and often those are very noxious, very cold or dry air, dusty environments, in and around pollutants such as pollutants from the back of vehicles, smoky environments, or even, you know, training for many, many hours in highly chlorinated pool environments. And the research, certainly over the last 4 decades, has shown a clear relationship between the type of environments where young athletes have to breathe in a certain type of noxious inhalant and the risk of developing respiratory problems over the course of their career. One of the things I want to talk about tonight and to truly emphasize is that not all breathing problems in athletes arise from a diagnosis of asthma. And yet, it is fair to say, and I'll explain some of the different causes of breathing problems in athletes or athletic people, that nearly 95% of the time, people have been labeled as having an asthma-related problem and have had a go on an inhaler at some point, certainly on their journey before they see me, and when they're trying to get to the correct diagnosis because the inhaler hasn't helped them. So tonight, I'm obviously going to share some experience of my work in this space, but I'm also going to really try and emphasize why it is important that we think beyond asthma. And again, just to go back to the point that you might be sat seeing an athlete who's casually talking to you about their injury, but in the course of the conversation mentions to you that their asthma is playing up or they can't get control of their breathing with their asthma symptoms, or indeed that you see them breathing in a funny way and they try and discount that as, oh, it's an asthma thing and the inhalers aren't quite right. Because that, in my experience, is one of the most common types of discussion point that people engage in this area. And yet it's an opportunity for us to move things forward and to think what really is going on so that we can help athletes overcome this problem. So I tend to like to give people the take-home messages for the talk right at the start, because then you can look at your emails or watch whatever's on TV at the same time, and then you can come back and think about whether I've given you anything useful from tonight's talk. And so I'm going to give you 3 take-home messages. And the first one is never trust what an athlete tells you about their breathing. I'll obviously expand why I should say such a controversial thing. The second thing is, if you want to think about why an athlete is breathless, and particularly if they're wheezy, always ask that athlete to take a selfie type video on their phone and then show that to you, because it can often give you a lot of insight as to what might be going on, providing it's obviously with consent. And the third thing is that I'm going to move towards the end of this talk to talk about a new approach that I have when I'm thinking about what might be causing breathing issues in an athlete, in this model called treatable traits, where it allows us to think about lots of things at the same time that I think offers the best chance to try and help people overcome breathing issues. So a bit of background about me. So I'm a respiratory physician, or in other parts of the world known as a pulmonologist, and I work at the Royal Brompton Hospital in South London. It's a chest hospital that treats all sorts of heart and lung diseases. And so half of my week is spent there. I look after people with a chronic refractory cough. So they've been coughing for many years, and it's often a dry or irritative cough. In fact, it's the same type of cough that many athletes might report that they have after they've been, cycling around a track, or they've been playing football in cold air. They cough a lot afterwards, and people say, well, it must be asthma. But often it isn't. It's this hypersensitive cough. And then the other thing I do for the other half of my week is I work at the ISEH, but I'm also involved with some research studies and helping various elite and professional sporting teams trying to optimize the respiratory health of their athletes and make sure they're in the best shape possible. And then comes the weekend. So on a Saturday morning, many of you, I'm sure, will take part in this event called the Park Run. For those of you who don't know the Park Run, which I'm sure is very few of you, based on the backgrounds that have been revealed already on the chat, this is a 5-kilometer free-to-enter run. It runs right across the world on a Saturday morning. You turn up, you enter. It's run by fantastic volunteers who give up their time to run these things at the weekend. And it really is a truly great event. And my local park run is at Bushy Park, where the park run actually first originated with a group of runners trying to run around and, if you like, beat their own best time, but try and, if you like, use it as a performance trial. And the Bushy Run has expanded over many, many years. So you see it on the left with the 13 runners lined up. And this is what my park run looks like now. But you'll notice one thing from that video is that I'm actually not running the park run, but I'm standing at the side here watching with my daughter. And we're cheering on my wife to run round. And as soon as she's run round, then I get to do the best thing that I enjoy most on a Saturday morning, which is that both of us head round to within the last sort of 800 to 900 meters of the park run. And we stand there, and I apologize if you know these individuals. This was taken entirely without consent. But I'm interested in watching people as they're running in at the very end part of the park run, because that is the point often when people are really looking down at their watches and they're trying to push themselves to try and beat their personal best time and try and run into the funnel as quickly as they can. And as I said, apologies if you know these individuals. So they were simply just to demonstrate breathing rather than good or bad breathing habits. But the point is that actually, by looking at that point, and I'll come back to this later in a study that we did, you can often see what is happening to people's breathing when it's put under the most physiological stress in a real world environment. I mean, of course, you could look at things like a shuttle run or a bleep test, but you'll often see at that point when people's breathing is causing them distress, it's when they're being pushed very hard. And so I finished the park run and I come home. And as soon as I get home, put the TV on, start watching sport, like I'm sure many of you do. And I'm particularly interested in looking at breathing patterns of potential athletes or people I've tried to help. And for instance, in cyclists,
that bit of a lead, and of course now it's just got to drop down into a pace that he can sustain. It's looking very.
I'm not really looking at the race, but I'm looking at how the thorax is moving or the abdomen or the lateral expansion of the ribs to see how the breathing pattern might be working or maybe not working when an athlete is apparently struggling. And so, I mean, I think if you're interested in sport, you're never far away from turning the television screen on and seeing an athlete struggling in some way, or grabbing an inhaler, or coughing, or reading things in the papers about people being distressed in the context of sport. And so it may not be particularly surprising that when you look at the study evidence to suggest or to look at how impactful this issue is, you find data which really backs up the statements I've already made about how impactful this issue is. And so here's a study done many years ago now in a postcode type survey of about 700 athletes in Canada. And you can see here that the very high prevalence rates report of breathlessness, of wheeze, of cough, that weren't diseases as per se, but were causing issues to athletes trying to partake and enjoy their sport. And one of the conclusions from that paper was that approximately a quarter of athletes have some form of respiratory issue. And in fact, respiratory issues are the most prevalent issue reported in people undertaking sport if they're going to report medical type symptoms. Obviously, we just had the fantastic London Marathon with a sub 2 hour marathon yesterday. I was standing at mile 25, and the speed they ran past at that point, it's simply mind blowing. I'm sure many of you have taken part of the marathon, and what a fantastic event that was yesterday. But if you look at studies of how that might affect people and cause respiratory issues, you can see from this very nice study now done by Paula Robson, and again, some time ago now, that it's very common after a marathon to develop some form of upper respiratory tract symptoms, be it a sore throat or a cough or a tickle in your upper part of your airway, which is often attributed to the presence of an infection, because people will say, well, your immune system was affected because you were hammering it by training for your marathon, and then you were tired, and then you became more fatigued, and the other factors that we associate with the increased likelihood of you getting an infection. But of course, what you actually see is that when you link that in with people who live in the same household in the same time period across a decent follow-up study, you find that that isn't really the case. And probably the simple act of performing such a vigorous sporting event inflames or somehow irritates the upper airway and certainly sensitizes it. Going back to that point that I was making, that things like cough that can occur in the context of sport don't necessarily indicate the presence of an infection or indeed asthma, but maybe just an irritative phenomenon that arises in that context. One of the things I say to people who look after sporting teams is it's very common to encounter, especially if you look after endurance athletes, an individual with asthma. I know I've sort of beaten up on asthma a little bit as the cause of symptoms, but it still remains the fact that it is the most prevalent chronic medical condition in athletes, and it's particularly common in those undertaking endurance sport or aquatic sport. You can see here those very high prevalence rates. And myself and Ollie Price did an analysis of the published data over the last 40 years. And what we found was that 1 in 5 endurance athletes have some objective confirmation of a diagnosis of asthma. So this isn't simply people making it up and saying, I've got something that sounds like asthma, or I want to use an inhaler because I think it might give me some advantage. But when you actually look in decent objective studies which have used good diagnostic tests, you find that it is fair to say that the prevalence of an asthma-related problem is much higher in endurance and certainly aquatic and winter athletes than is to be expected in the general population. The final point I just want to make, just to emphasize the importance of this area, is this data that shows consistently that in elite international competitions such as the Olympic or Paralympic Games, when athletes train for a whole Olympic cycle, they've prepared, they've arrived, they've got themselves into what they think will be the best state possible. It is not uncommon for them to develop a respiratory tract infection at that point, and it's estimated that somewhere between 3 to 5% of athletes at a major event such as the Olympic or Paralympic Games will develop a respiratory tract infection. And whilst you can argue that in many cases that might not impact their elite performance level, it certainly does, and there is certainly evidence to suggest that those who fall outside the podium level will affect the ultimate position that they will finish in. And so in terms of developing and progressing your career and actually being able to achieve the highest result possible, there is good evidence to suggest that a respiratory tract infection in the context of the acute setting in an Olympic or Paralympic Games does affect your performance. So just to round that off, often I'm invited to speak at sports and exercise medicine conferences, and there's obviously, often two parallel sessions running. There's one on ACLs and hamstring injuries. And then there's a sort of parallel session room where there might be myself, a dentist, someone else talking about an issue such as some cardiology, whilst the room into the injuries is completely packed and people are trying to peer in at the back and see what's going on, there's sort of 5 or 6 people sat in the lecture listening about respiratory disease. And that might be because it's me or because of the topic area. But the thing I want to impress upon you here is that if you think about the burden of symptoms that are reported by athletes, the most common chronic disease and what happens or is most likely to affect acute performance in the context of an event such as the Olympic Games, and then, respiratory illness is very high up indeed. In fact, some would argue would take the top step of the podium there. So if you're working in and around athletes, particularly if you're working in squads, particularly if you're looking after teams and you're responsible for their health and their endurance, or their aquatic or their winter sports athletes, I really do think getting a good handle on this area is important, because it's more likely than not that you're going to come across problems over the course of your career trying to help these people do the best they can. I want to change tack slightly and just talk a little bit about some work that I did with the English Institute of Sport, which is now, of course, known as the UK Sports Institute. And I've been working with them for about nearly 10 years now. And this was a take from a discussion with an individual who sat in the middle there called Craig Ranson, who I'm sure will be familiar to some of you. And at the time, he was the director of athlete health. And one of his roles was to try and look back through the funded or podium potential athletes over the course of the previous Olympic Games and work out what were the sorts of things which were impacting performance or ability to translate, the investment in athletes to medal potential and to actually get them into the steps of the podium. And so he did quite a big analysis, which I obviously won't share all tonight. But one of the things that he came up with at the end was that, and this was my first interaction with him, really, was when he came to me and he said, look, we've done this piece of work. And what we find is that respiratory illness is the biggest so-called injury problem. I've got to use that term sort of fairly carefully with this audience, but a performance threat in our elite athlete cohort. And this isn't really part of the detailed study, but I mean, essentially, within that system of the EIS and the UK Sports Institute, athletes are carefully monitored, their events are logged, the duration of those events are logged. And from that, you can start to build intelligence about what are the most impactful events and performance insults. And therefore, you can start to work out where individuals' training may be insulted. And so you can see from this plot here, upper respiratory tract infection is a very common illness account, and of course dwarfs things like gastroenteritis and the other things that you can see on that chart. And so when we do an analysis of those events and we look at how long a respiratory illness takes an athlete out for, what you can see is that the vast majority of athletes get better pretty quickly from a respiratory tract infection. So, within a few days, and you will have been through viral infections where you have a snuffy nose and you feel a bit under the weather and you feel like you can't train for a day or two. And day three, you feel like I should do something light, and then you start to build back into it. But then there's this tail of individuals where people struggle for, over a month. And of course, we really saw that in the early parts of the COVID pandemic, but we still see it in athletes after respiratory tract infections, and they end up fatigued and they feel that they can't get back to performing as they were previously. And when you put all that together and you look over an Olympic cycle and you look at the number of days lost to full training, what you actually find is, and certainly this is the analysis that was presented to me when I first met with Craig, was that when it was summed up over all of the funded athletes within the EIS at the time, it accounted for over an Olympic cycle prior to a games, almost 11 years of lost training days. So, it's a big impact. And I mean, I don't need to talk to you as an audience about what might be viewed as marginal gains, but of course, trying to build sustained training is not only important to be able to give athletes the building blocks which allow them to then develop their best performance, but at the same time, having a week and a half off with a respiratory tract illness and then performing contact-based sport runs a much higher risk of an injury as well. And certainly something that we reported in the context of the impact of the COVID pandemic on rugby league and rugby union players, on how to sort of make sure that coming back from a COVID-related illness didn't then cause an injury when you're coming straight back in and having to load the muscles and joints and get back into contact sport. So it isn't simply about respiratory illness and a cough and an irritating snuffle or those sorts of things. It's about what happens when you're starting to lose training capability and then the building blocks that you need to perform at the top level. So on the back of that, the EIS funded a piece of work which I was involved with leading in collaboration with Mike Loosemore, who some of you will know, and Anna Jackson, who is one of the physiologists at the UKSI. And we did this work in collaboration with the ISEH, the EIS, and also Imperial College. And my role within that project, amongst lots of other things that were going on to try and help with this issue, was to say, well, what can we do that might allow us to try and see if there are factors in these individuals that we're able to detect, then to try and address, and then to try and favorably impact the frequency of respiratory tract infection they're getting, but also to try and reduce the duration of symptoms that individuals get. And at the time, you might remember that I talked about working at the Royal Brompton, and at the time, we were heavily involved in running this process called a systematic assessment. And essentially what that means is that when we were seeing people with asthma symptoms that were refractory to treatment, or people who were still struggling with a high burden of symptoms, we would undertake a series of investigations at the same time in the same individual to try and really characterize what were the different factors that may be impeding that individual's ability to respond to asthma treatment. And I'll talk about that in a minute in the context of what we might do in athletes, but essentially what it really means is, have you looked carefully at nasal function or sinonasal problems? Have you looked to see whether there may be problems at the level of the voice box, so in the middle, what you might call the middle airway? Have you truly assessed the asthma process? Have you looked outside the airway and thought about things where people might have an abnormal breathing pattern? So it can look a bit like asthma, can make people feel breathless, but it's certainly not going to get any better by inhalers. It's going to get better by targeted therapy, which helps people to breathe better and improve their breathing pattern. And then some other things around it, are allergies managed well? Is GI reflux causing problems? Is it coming up? Is it irritating the airways? Is it making people more susceptible to infection? Are people taking their treatment in the best way possible? Are there psychological aspects which are impeding either adherence to treatment or making people feel more breathless, or contributing to some of these other factors which I'll show you on the screen? And of course, it's called systematic because you think about all of these factors in every single individual. Now, some of them will be discounted relatively quickly, but others won't. And as I'll share with you, often people have more than one thing going on at the same time. So what did that look like in reality for the athletes that we saw within the EIS program and the UKSI now? Well, what we did was we said we're going to assess all of these factors, some of the factors by questionnaire, because that was the most effective and validated way to do it, but some of it by also doing a single visit assessment, which allows us to do things like check nasal flow, look at lung function, look at how twitchy or irritable the airways are, and then bring all of that, check the allergies, and then bring all that together to provide a sort of overview or a comprehensive systematic assessment that we would feed back to the medical team, and then the medical team could discuss with the athlete and then instigate some changes. And so in reality, it kind of looks a bit like this, where you get this sort of traffic light system where, if you've got no sinonasal issues, then you get a green. If you've got problems with your breathing pattern, there's red, and that comes back with some advice underneath it. And alongside that, we were taking relatively complex immune function tests and looking at how the immune function was working alongside some research projects to provide us with some better intelligence in this way. So what does it show? I mean, essentially what is interesting here is that there is a very high prevalence of these various different component problems within the respiratory system in a cohort of athletes who are preparing within an Olympic cycle. And so, for instance, you can see at the top of the screen that about half have some problem with sinonasal issues. About 30, just over 30% report problems with laryngeal or throat issues. A high prevalence of people with asthma-related issues. And you can see also a high prevalence of issues with a breathing pattern disorder. You will recall that really the aim of this work was just trying to look for factors which were different between those who'd been deemed to be susceptible to infection. Remember, our main aim was to try and look at that insult or the primary factor which we felt was impeding the performance of the whole squad, which was these recurrent illnesses, these days of lost training, the impact of infection. And so within my component of this work, I did find that there was a significant difference between those who were susceptible to infection and those who were not. And particularly, interestingly, not in the markers of asthma, but particularly in the markers and the prevalence of sinonasal or rhinitic problems, and also in a problem with a sensation of an abnormality within the larynx. The other thing we found was that whilst, almost 8 out of 10 athletes had at least one of those respiratory issues that were shown in that picture, showing you the different types of components we were looking at. In the same individual, 2 problems were evident in at least 60%. So the point, and certainly one of the conclusions in this BGSM blog, is that looking for a single cause of a problem or looking for a single potential risk factor for respiratory tract infection isn't likely to be the whole answer, and it's often the case that people have more than one explanation which needs to be found. So I said at the start of this, I was sort of hired on the promise that I would try and reduce the risk of infection in an Olympic cycle. And my involvement started just after Rio in 2018, as I shared with you. And certainly I delivered for the Tokyo Games by 2020, when we saw a huge drop in the number of infections at the Tokyo Games. Some of the more astute or those with better memories will recall that the Tokyo Games was run under sort of pandemic conditions. And so whilst I'd like to think that our intervention and our assessment significantly improved and was responsible for this, I think the reality is probably it demonstrated simply that if you can keep people away from infections, it's probably far more impactful than any of these little things of looking at these sort of systematic factors. Regardless, I was invited back to try and help with some other work, particularly with the GB rowing team. And within the cycle before Paris, we spent a lot of time with the GB rowing team, again, delivering this systematic assessment approach to try and identify problems. And you can see that broadly we found the same thing in the rowing team, that at least one respiratory problem is evident in 80%, and 2 problems are evident in at least a half, and sinonasal is a big problem. You can see here also the high prevalence of a breathing pattern issue that we see in this cohort. And I'll come on to why I think that is particularly relevant, and I think very relevant in your field of work. And I'm sure many of you have lots of expertise in this area already. GB rowing did well, which was pleasing to see with that. And again, I could take no responsibility for that because they're a fantastic squad who are trained by great coaches, S&C and physio teams. One of the things that has emerged from this sort of analysis showing the impact of this type of issue is that the International Olympic Committee have certainly realised that respiratory health is a key and important issue. And one of the key driving factors behind the IOC, certainly medical code, is to try obviously to safeguard the health of athletes and minimise the risk of physical injury. But I mean, you could extend that to say, of course, health is equally important. And so they convened a panel of experts, which I was lucky enough to be involved with in 2022. And we published a couple of papers which are free to access. And I put these up because they're hopefully very accessible. They've got flow diagrams within them. They're published in the BGSM. And there are two parts to these. There's one that looks at factors associated with infection. So if you have any questions about, what might you look at to try and see why your athlete is more susceptible to infection, or what are the risk factors, for instance, with travel that make your athlete more susceptible? And these are really helpful. This is a really helpful document. And then second part of this document talks really about some of the things I'm going to talk about in the latter part here, which is how you actually get to a diagnosis and think about the different causes of breathing issues. So let me come back to my clinic. So I run a sports respiratory clinic at the ISEH, which is in Tottenham Court Road. I see a variety of different cases. I'm often, as I said, seeing athletes which, someone has labelled them as having an asthma type issue. I've seen people with recurrent infections, chest pain, underperformance, those types of issues. This is the sort of classical case I'll tend to see. So hopefully you can hear this, but this isn't actually my patient, but someone who presents with the type of typical description of what might be causing their problem. So if you listen carefully to the wheeze and just look at their breathing distress. And what typically follows from that sort of case discussion is that someone comes in, they say to me, look, whenever I try and run, I feel my breathing's holding me back. I get wheezy sometimes. I feel like I can't get enough air into my lungs. My lungs don't expand, all these sorts of things. And, it's really frustrating as I open the talk with. And often these individuals have been through an escalation in asthma treatment. They've got higher and higher doses. They've tried different inhalers, sadly, none of which have particularly moved them forward. And I've got to try and work out what to do next. So a few things just to think about. And when we take a history in this space, we often, first of all, want to think about so-called red flags. And there's a few of those. I mean, clearly, just because you come to see a breathing doctor doesn't necessarily mean that you might have breathlessness that's arising from a cardiac problem. It's important to think about things like having palpitations, having excessive central chest pain, things like coughing up blood, sharp stabbing chest pain, profound fatigue, lots and lots of muscle pain. Those might be features which can sit alongside some of the conditions I'm going to talk about, but if they're prominent features, then they should alert you to think about, other tests such as imaging or other things to look at the lung. The thing I would say is that by and large, when I see particularly young athletes who report problems with their breathing, particularly when they're performing hard exercise and those symptoms are coming on when people are exercising intensely, the diagnosis comes down to one of three different conditions. So they either do have some form of asthma, which has either been inadequately assessed or undertreated, or they have a condition where the voice box is closing in a condition called exercise-induced laryngeal obstruction, or ILO. And I'll show you a video of someone who's developed that. Or the third entity, called a breathing pattern disorder, but often goes under different terminology. So some people got dysfunctional breathing. Some people still use an old term called hyperventilation syndrome. But essentially, it's a problem where breathing isn't doing what it's supposed to do, and it's not adapting to the type of challenge that's placed. And the important point here is that these are presented in a Venn diagram because they overlap. And because, as I shared with you before, thinking about things systematically, the same conditions can be present as more or more of the conditions can be present in the same individual. And that can confound diagnosis, but it can also confound and complicate treatment. So let me just walk you through some of these conditions and just talk to you about how I think about them. So This is exercise-induced asthma presented in a sort of physiological representation. And in order to make the diagnosis, we get people to do breathing tests. And we particularly use a test called spirometry, where we get individuals to breathe into a little tube, basically, that measures the amount of air that comes out in the first second of the breath. And you can see there that we get it done at baseline. And then we get someone to typically do, say, a sporting challenge for 6 to 8 minutes, super hard exercise. They stop doing the exercise. And then for the subsequent 20 minutes after that, we ask them to repeat that measurement. And in the context of exercise-induced bronchoconstriction, the narrowing of the airways causes a reduction in airflow, which you see by a greater than 10% fall in the amount of air that comes out in the first second, the FEV1. And you can see that this is a post-exercise phenomenon, and that the response, that abnormal fall you see in the clear see-through dots, is attenuated by the use of an inhaler such as salbutamol or terbutaline. Now, the thing I want to highlight about this is that this is a post-exercise phenomenon, so you can see that really the fall in lung function is occurring post-exercise. Now, you might think that it's easy to diagnose exercise-induced asthma just by simply asking someone about their symptoms. But this very seminal study showed many, many years ago that when you take a group of athletes and you ask them about whether they cough or they wheeze or they get breathless, and then you do a decent exercise test that looks at that change in FEV1, like I showed you on the previous slide, what you find is a really poor relationship. And in fact, one of the common conclusions from this paper that's often cited is that you might as well toss a coin in the air when you're trying to make a diagnosis of asthma just based on what an athlete tells you. Let me just explain that in a different way. So this is Sanjay Sharma. He's a sports cardiologist and he's screening a football team here. He's looking at the cardiac function and he's screening. And he'll do that for lots of different football teams over the course of the year. Now, we can use a similar type of approach to screen and look at making a diagnosis of asthma in athletes. And this is a test we use. So it's a test called EVH, which is a dry gas inhalation test. An athlete sits in a chair, breathes in and out for 6 to 8 minutes, and then we look at their lung function before and afterwards. And if we see a greater than 10% reduction in their lung function, like I showed you before, we're able to say that actually it's likely that they have some tendency towards exercise-induced bronchoconstriction. So in this study a number of years ago, we took this test and we screened or looked at 42 professional footballers, and these were individuals who'd previously been given a diagnosis of asthma, often simply based on the symptoms that they described. We put them through this test, and what you can see here is that at least half of them didn't demonstrate a fall in their lung function with the challenge test. A bit like the Rundell study that I showed you before, you might as well have tossed a coin in the air to work out whether they did or didn't have exercise-induced bronchoconstriction or asthma. So that brings me to my first take-home message, which is never trust what an athlete tells you about their breathing. And I don't mean that to any sort of pejorative or belittling way. It's just to say that, we have known from many, many decades of research now that when an athlete says their symptoms are down to asthma or it's asthma that's making things worse for them, the first thing I always ask is, well, how was your asthma diagnosed? Or, what were the sorts of tests you had done? More often than not, you find that people have just had a cough. They've gone off and spoken to someone who says, that sounds like asthma to me, and they've been started on an inhaler. And so often that diagnosis isn't very robust. And I think it's beholden on people who interact with athletes when you're chatting to them, if they report symptoms to you, to say, oh, how was that diagnosed? Well, sometimes the diagnosis may not be robust or may not be right. Maybe it's worth getting that checked out properly. So what is happening if not? I've shown you the video already. Of an athlete who's really struggling, and you can see, if they said to you, I've got wheeze and I'm breathless, you'd first of all think, they must have asthma, really. So back to the park run. I showed you what I do at the park run, which is running towards, drive right around to the back of the finishing line and look at what happens to athletes running into the funnel. Well, a few years ago, we did this study run by Ollie Price up in Leeds. And essentially, we looked at runners that go around the park run, but we asked runners if they'd be happy enough for us to make a sound recording of what it was like when they came into the funnel at the end, and to complete a questionnaire to see if they'd been distressed by their breathing. And then we characterize that to work out whether individuals were struggling with breathing when they were breathing out, breathing in, had a cough, and whether that related to any symptoms or features of distress. And what you can see from this was that about 1 in 10 of the runners had some report of problematic symptoms, and they had an audible feature of some sort of noise within their breathing tract. And the important thing to highlight from this is that the most common abnormality we found was a noise when people were breathing in a so-called inspiratory wheeze. And whilst many athletes were running in and they were distressed and relatives were handing them their blue inhaler to use at the end of it, what I'll share with you is the actual diagnosis was far more likely to be coming from the upper part of the airway and around the larynx in this condition, exercise-induced laryngeal obstruction, and therefore the inhaler really wasn't going to help them. And so, of course, not all wheeze comes from asthma. And if you narrow any part of the airway and push enough air across it, you end up with turbulence, and turbulence causes a wheeze and thus looks a bit like asthma. About 20 years ago, a group in Norway started to do this test where they put a camera inside the nose, they look down at the voice box, and then get individuals to do exercise. And then you can look at exactly at the time that someone gets their symptoms and see that the larynx is closing up and causing the turbulence that is associated with the wheeze in this condition called exercise-induced laryngeal obstruction. And so here you see it in real life. You'll see the larynx down below on the screen. Someone's running, and you can see it's folding over as the individual is doing more and more sport. And that's exactly what it looks like inside the throat. You done?
Yeah.
And there you go, you can see there. So those are the sort of flappy structures which sit at the back of the throat above the vocal cords and fold in and cause this condition, exercise-induced laryngeal obstruction. Now, studies have shown this is a condition which is affected when the airflow is at its maximal. And so athletes will often report it occurring at go time or a point when they're just finishing a race, or if they're on a bike when they're attacking or going up a particularly steep incline in a race. And then it sort of settles or abates quite quickly. So the athlete that mentions to you that they have a loud wheeze and it's hard when they're really doing intense exercise and they need to come off and get their inhaler, again, it's an opportunity to think, is it really asthma? Because actually it's far more likely for that peak exercise phenomenon to relate to a larynx closure and this condition is ILO, whereas I showed you physiologically on the previous studies, asthma tends to be a post-exercise phenomenon, and often athletes with symptoms of asthma tend to report that they kind of struggle with their symptoms at the start of exercise, and then often when they stop they feel their chest is a bit tight and they're coughing. But that very tightly associated breathing issue with peak exercise with a loud wheeze is more often than not exercise-induced laryngeal obstruction. So one way to try and work out what is going on is to try and get an athlete to record a selfie when they are symptomatic. Athletes are always carrying phones around, taking videos of themselves, etc. But if you ask an athlete to record themselves when they're under extreme physiological stress, and then show you that video, then essentially you can start to get a feel for where in the breathing cycle that problem might be occurring, noting that ILO tends to occur obviously when you're breathing inwards, and if you have a loud wheeze associated with it, but you can also look at the pattern of breathing. Here's just going back to that test where I showed you where there was a dry gas test where you're breathing in. We're often interested in looking at the pattern, and you can see in this individual who's doing that test to try and work out whether they've got asthma, that they've got very high, what we call apical movement of the chest, and basically all the air is coming in and out just by them lifting their chest up and down. And so for this individual, when their test was finished and they were negative for exercise-induced bronchoconstriction, the actual diagnosis was of a breathing pattern disorder, which I'm sure we can talk about subsequently. So my second take-home message, selfies I think are very useful. They give you insight. They allow you to look at the breathing pattern. They allow you to look at the nature of the timing of a wheeze, and they can be very useful, I think, in the diagnosis of exercise-induced laryngeal obstruction. Not least, asking an athlete to take a selfie on their own phone and bring it to show you, or indeed to take it to their doctor or to whoever they're presenting to, and to say, look, does this really look like asthma, should spark a discussion that says, look, can we just talk about whether we need more tests for this now? And so my final point is about thinking about treatable traits. So I've shown you this slide already, which looked at all these different factors that were assessed systematically in the same athlete. And one of the things that I've come to the conclusion is that when you try and treat an individual, even if you've confirmed the diagnosis of asthma, you send them on their way, with an inhaler and you say, well, here's your inhaler, your diagnosis is asthma, goodbye. More often than not, you find that athletes come back and say, it's made a big difference, but, I'm still struggling. I still have a problem. I can't quite work out what it is. And I think this speaks to the point that actually it is more likely than not, from the basis of the studies that we've done, that individuals have multiple different problems in the same time or the same scenario or at fluctuating times. And so in the world of airways disease and asthma, certainly from Australia, there's been a big push to talk about this thing called treatable traits, which in essence is a way of looking at the different factors which may be contributing to a certain symptom complex or a disease. These traits need to be identifiable, they need to be modifiable. And really what I want to do is try and push this or present this as a way of thinking about the breathless athlete in front of you, in that they may have asthma and you may be able to confirm that and you may think your job is done, but it's not likely that that's going to explain or fully enable you to treat that individual. And you need to think about things like the breathing pattern, and breathing pattern abnormalities often sit side by side with asthma. They may have issues to do with stress and anxiety that obviously amplify themselves in and around tough parts of the season. There may be airway reflux, which is also contributing and making people cough, but then affecting sleep. So I suppose the point I'm trying to make, and you'll be more than familiar with all these different factors when you think about injury and injury management, is to think, how can we bring these same sort of skill set to thinking about breathlessness and to moving that forward? So hopefully given you a walk through some of the ways I think about this. I've given and shared with you some resources. I think my key take-home messages are always challenge a diagnosis of asthma when an athlete casually mentions it, obviously in a nice way. If you can and you are working with an athlete and you want to try and help them, then you can get some information from field testing them and stressing them and or asking them to do that themselves if they're happy to do that on their own phone and then show that to you. And then thinking holistically about all of the different factors which may be contributory to breathing issues. Some of you will be sitting here and thinking, he hasn't actually talked about how to treat any of this. I've deliberately left some time at the end so that I can take on and talk some of these things. And I think that's down to your own skill set and the sort of questions you'd want to know about how you might approach some of these conditions, because you certainly may not want to know about the ins and outs of asthma treatment, but you may want to talk a bit more about the breathing pattern. So I was going to leave that to the discussion. Anyway, thank you.
Thanks very much, James. Excellent, and thanks everyone for joining. Great to see people from all around the world and different roles as usual. If it's all right, we had one question in by email. Are you happy to take that one first, James?
Yeah, of course.
So this was from Siobhan O'Donovan at Posture Fitting, and Siobhan says, has any consideration been given in any work situations in relation to how breast weight could impact female athletes, especially in terms of suboptimal breathing patterns and capacity? She's currently looking at some research and would be interested in any sort of insight or advice that you can offer in that issue.
I think that's a really important question. There's a nice piece of work done by a colleague I work with called Eric Harbour. And he's got a nice website as well with some information in there. But he published a paper last year looking at the impact of certainly different constriction around the upper chest, particularly also with the sort of support garmentry that people might wear when they're challenged in that area. And if it doesn't fit or is inappropriately tight or restricts the chest, it has a big impact on the ability of the thorax to expand and to allow your breathing pattern to generate itself in the normal way as you start to do more vigorous exercise. So I'm not an expert in this area, but I would signpost you to the work by Eric Harbour. And I think if you dropped Eric a line, if you had any further questions, I'm sure he'd be able to share his experience with that area.
And does treatment for breathing problems sometimes focus on postural issues as well? Anyway.
Yeah, I mean it's crucial. The posture is so fundamentally important in terms of allowing the diaphragm to move in the correct way and to allow the chest to expand. So hunched postures impede that ability for the lower thorax to expand. But also, I think more and more we talk about crunch neck positions, which potentially alter airflow through the larynx and through the upper part of the airway. And certainly when you're seeing, for instance, a cyclist who's in a very crunched up time trial position, struggling to get air in or doesn't feel or feels like they're suffocating in that position, it's kind of understandable when you see the way the airway may be kinked or shaped and the inability to expand the chest in the most appropriate way. So yeah, I think posture is key, and I'm sure many of the attendees, spend a lot of time on the breath work to try and improve the posture, and then vice versa. It's just the two things are just sort of tightly integrated, aren't they?
Yeah, great. No, thank you. So we've got another question from Mark Byrne. Mark says, what role do you think increased mouth breathing plays compared to nasal breathing? Would you say increased nasal breathing can help reduce some breathing issues in athletes?
Yeah, and there's been a lot of interest in this area, of course, with people talking about the benefits of mouth taping. People tend to promote or have promoted nasal breathing with the premise that, of course, the nose acts as a natural brake. It also humidifies the air before it enters the upper part of the respiratory tract. And, there are some who've put forward the argument that it releases nitric oxide, and therefore has other broader benefits. I do think, and my take on this is that people should breathe in a natural way that feels natural to them. And generally speaking, people tend to open their mouths at a certain given exercise intensity. That's debatable as to what intensity that is. And different people are different, but somewhere around sort of 35 to 50 liters per minute. People go to an oral breathing pattern. But there is certainly, I think, something or some merit in submaximal and resting encouragement of nasal patterns. And I think sort of highlighted some of the potential benefits in that respect. Whether people can adapt their breathing pattern so that they can use a nasal predominant flow throughout or towards much higher intensities, there's some evidence that you can train that response pattern. And I think more research is kind of needed in that area to understand the benefits of that particularly.
Is it potentially a psychological thing of if you feel you can breathe comfortably through your nose, that you're kind of at a level where you're not under as much stress potentially as well?
Yes, potentially. I mean, and there's competitive advantages as well to people seeing you breathing through your nose. You look as though you're not actually working that hard. Um,
Yeah,
I
I
didn't.
know.
Go on.
Sorry, a colleague. I mentioned your presentation to a colleague today, and they said, "Oh, it was amazing watching the elite runners in the marathon yesterday. How many of them were running with their just breathing through their noses?"
Yeah, I've seen people running it with their mouth taped as well. So um, I think it's interesting, and I think we actually need more research and more high quality research to look at the performance benefits. They're not easy studies to do, but I know there's a number of groups around the world that are doing those studies at the moment.
Brilliant, thank you. So Fiona has asked, have you observed greater prevalence of breathing pattern disorder in particular sports?
I see there's a couple of areas which are really challenging in this area, and one of the key areas I would say it does appear to be a high prevalence, and it's particularly difficult to treat is in swimmers. And of course, swimming's placing lots of different challenges on the athlete at the same time. You have to be able to time your breath stroke, obviously your breath cycle within the swimming stroke. And obviously that has to be done at different times depending on the speed you're going and the intensity you're performing at and the stress you feel under. And then you have to rotate your head in different ways. So I think that those sorts of challenges make it perhaps not surprising that individuals struggle with breathing pattern issues. And sometimes that translates to post-swimming activity where, for instance, if you watch it on television, you can see athletes who are being interviewed after some 5 minutes after the event's finished, and they still appear to have irregularities in their breathing pattern, which is certainly disproportionate to the ongoing sort of metabolic recovery period and the demands on ventilation driven by that. So that's one group. Rowers is another group where, again, you've got multiple challenges placed on the thorax concurrently, and rowers sometimes have to adjust they do adjust their breathing according to their stroke rate. And there are different breaks in the breathing cycle throughout a normal rowing stroke. So I think there's probably two particular sports which present a challenge and a challenge to treat as well.
Okay, that's great. Thank you. Chris has asked, alongside their work as a sports massage, they're a professional, classically trained singer. Is a singer likely to get similar issues to athletes?
Yeah, that's really interesting. I mean, I'm obviously see a very biased view of the world because I'm obviously seeing people who've got problems who are usually referred to me. And it's inevitable whenever I see classically trained singers, the first thing they say is, well, it's not my breathing pattern because I've been trained how to breathe. They get that in within the first 2 or 3 minutes of a consultation, and yet it is inevitably the answer that it's their breathing pattern that's not right. And I work with a fantastic group of respiratory physiotherapists, particularly Julie Backley at the ISEH, and she's able to make big inroads helping with their breathing pattern. They say, oh well, maybe it was just off on, it's not been so good recently or things. But yeah, you'd like to think that they've been trained to breathe, but I wonder whether the training somehow instills over recruitment or abnormal function in some individuals. So I'm not a breathing physio, so I don't want to sort of overstep in terms into others' areas of expertise, but that would be my comment on that area.
Yeah, and I guess there's a lot of transferable learning from sort of the singing and music into sport, isn't there, as well, in terms of breathing techniques?
Yeah, I think so. And some people are trying to use music to entrain certain patterns into breathing. So again, there's this move towards thinking about, can we entrain breathing patterns in runners? Can we think about this thing called coupling? And it may be that music can be used to help in that respect and to use the beat of music to try and encourage certain breathing patterns that can help.
Okay. Have you got time for a couple more? Is that right?
Yeah, of course.
So Aaron's asked, linked to the last couple of questions actually, do you refer breathing pattern disorders to any specific discipline for treatment, and how many sessions does it take for people to improve their breathing pattern on average?
Yeah, so as I said, I work with respiratory physiotherapists, but the respiratory physiotherapists in my team tend to also work with MSK physios. And often there is a sort of crosstalk and discussion, particularly if we think there's thoracic mobility issues, if we think there is pelvic floor issues, if we think there are clearly locked up spinal issues. And I think that closer collaboration, well, that needs closer collaboration. Certainly, it's not something that works very well in the NHS, where you will have the scant coverage of respiratory physiotherapists within the NHS, and actually their ability to access people with the right MSK expertise is very limited. So yeah, if you wanted an ideal world with someone with a breathing pattern disorder, I think they see a respiratory physiotherapist, an MSK physiotherapist, and a psychologist as part of that team. And people will lean in or need different quantities of each, but I think you need that team available for every individual.
I guess that's where people involved in elite or professional sport can benefit, because you've got that multidisciplinary team working together already.
For sure.
And then one final question, if that's all right. So Nicole has asked quite a broad question: what sort of advice treatment should be given to patients with EILO?
So EILO, the first step in our treatment is trying to modulate the way that air gets in through the back of the throat. So, it's an issue where the states of high airflow, particularly when you're performing vigorous sport, as the air gets into the back of the throat, it has to decelerate, and then that's probably what causes the structures to be pulled inwards in sort of vulnerable people in that state. And so the physios tend to use techniques where they put like a breathing break at the start of the breath in, and then a sort of slower exhalatory flow with something like what's called pursed lip breathing. and then trying to get the diaphragm to work better and relax the shoulders. And those are the sorts of things. I actually use a technique called Hoover, which is basically a technique where you're getting people when they're running to do a sort of a on the way out, and then sort of a mini vert at the very start. So they go hoo fa, and that's the sort of breathing technique I sort of tend to start with. But again, physios probably listening to this saying, "Oh, what's he talking about?" So I do those things. The other thing to say is that for a select proportion of patients with ILO, if they've failed therapy-based intervention, there is a surgical treatment option. And if you just think back to that video, the majority of people, the condition is caused by the sort of arytenoids sort of flapping over and closing the larynx. And you can have a laser surgical operation to get rid of those structures. And then that cures the condition. So there's different options to treat it for sure.
Brilliant. Thanks so much, James, and thanks everybody for the questions. As James has suggested, please do. He's kindly shared his contact details, and would you recommend people have a look at your website for resources and information?